Good afternoon, everyone. My name is Thaoussi Uwera. I'm from the University of Rwanda. My background is IT, and I have a specialization in health informatics. My topic today is about facilitation strategy for improved use of electronic immunization registry in Rwanda and implementation research study. The presentation will cover introduction and background, research gap and objectives, method, result, conclusion, and recommendation. This study was funded by the Regional Center of Excellence in Biomedical Engineering and e-health operating under the University of Rwanda, and it was approved by the Rwanda National Ethics Committee and the Norwegian Regional Ethics Committee for Health Research. As the introduction, as the technology developed, health systems are moving from paper-based immunization record to the electronic immunization record through immunization information system. The electronic immunization registries is the part of the immunization information system and to have the potential to support the immunization program and its monitoring by providing large set of good quality data. With this picture on the right side, we see that the health workers are capturing the information about vaccine dose delivered to patients at the point of care, and the same data entered into the digital electronic immunization registry. And these e-registry data are used to inform service delivery and vaccination program monitoring and many more, and they are accessible by the Ministry of Health, the health worker themselves, and the clinics. However, inadequate implementation planning may result in failure to demonstrate predicted benefit of the tool. For Rwanda context, Rwanda has achieved the high coverage rate for childhood immunization almost in all indicators. For example, coverage of third dose of pentavalent vaccine was at 97% in 2018, and coverage for measles and rubella vaccine was at 99% in 2018. But lower coverage rate observed in a certain group based on socioeconomic status or place of residence. With that, some children were still being left behind continuously across the years. To resolve that issue, Rwanda has implemented an electronic immunization registry called e-tracker. The e-tracker is a web-based, and it is built on the district health information software tool, or DHIS2. The e-tracker was introduced to improve the efficiency and effectiveness of the national immunization program to achieve 100% coverage. However, several issues identified in the e-tracker implementation. The e-tracker used as a secondary data entry tool in addition to paper, that resulting in added documentation burden. The e-tracker also used by the data manager instead of responsible immunization nurse. This was linked to the limited training and the huge workload due to shortage of healthcare personnel in health facilities. The health facilities also experienced the turnover of trained staff and connectivity issues. So with the research gap, in 2021, a reported 18.2 million infants worldwide did not receive vaccinated, associated high death in low and middle income countries. So in Rwanda, with the recent assessment done about e-tracker data, we found 75% of available data in the e-tracker were only for indicator of BCG. BCG is an indicator of vaccination that are given to the newborn right after birth. Other immunization indicators that account for less than 15 of recorded data in source document. So there were dropout and a possible coverage rate over 100% due to the denominator issues. So objective of this study was to co-design facilitation strategies with the users to facilitate phase-out paper documentation and reporting and enhance e-tracker use by the responsible immunization nurses at the point of care. And then evaluate the facilitation strategies with the same users to see if there is a change. For design, we use the implementation strategy design with mixed method approach and quasi-experimental design for implementation and evaluation of facilitation strategy, where we had intervention group of 12 nurses or 12 health facilities from 2 districts, and you had the control group of 34 nurses from 34 health facilities. The total of 46 less e-tracker performing health facility constitute our setting, and they were selected based on Rwanda Biomedical Center, that is an implementing agency or operating under the Ministry of Health, responsible for healthcare. That is the report highlighted the performance of all districts in Rwanda, how they are performing about the e-tracker use. So we selected these 46 health facilities from that report, and our participants were the immunization nurse. In the co-design, we made stakeholder engagement, which constitute meetings and workshops, and we conducted focus group discussion with users. Those are 12 immunization nurses in the intervention group, and it took 6 participants per each group. Our discussion were guided by the high parish framework, that is the popular implementation research framework. Our implementation action contained the training of trainers, that is champions data managers, and the nurses collaborative group for learning and recorded videos. And those training of champions to nurse 6 months. We made also evaluation after that implementation, 6 months post-implementation, using process evaluation questionnaire that assessed 3 key measures. We assessed acceptability of intervention measures, appropriateness of intervention measures, and feasibility of intervention measures. The questionnaire were administered online via email of participating nurses. So we selected 3 facilitation strategies. That was educational material, running collaborative, and identify and prepare champions. Those strategies were selected from the Cochrane Effective Practice and Organization of Care, or EPOC taxonomy of implementation strategy, and the compilation of implementation strategy resulted from the expert recommendation for implementing change, or ERIC project. So with the analysis, our focus group data, we used thematic analysis of data. Themes were organized in accordance with the construct of IPHC framework and summarized them in accordance with the study objectives. We also used the in vivo analysis software to manage themes and codes. For the process evaluation questionnaire data, we used descriptive analysis to evaluate the level of training satisfaction and social demographic data, and independent t-test to examine whether there is a significant difference in implementation outcome, which were acceptability, appropriateness, and feasibility of implementation with our alpha 0.05. This was used through SPSS version 2025. So one of the results from the focus group mapping the barrier and facilitation strategies were about the context and the recipient and the facilitators. With the context, the recurring theme was about a conducive environment of working because of shortage of staff. And for the recipients, the main recurring theme were about the insufficient training for the users, where they appreciated the videos that we co-designed, saying that it will be helpful instead of calling colleagues several times asking for the same thing. They can replay the video to see the challenge they face during the e-tracker use. They also mention about the facilitation that the readers, especially the head of health center or health facility, should be involved in the process so that they can facilitate championship process. We mapped the result according to the IPHC framework. The IPHC framework have 4 constructs: innovation, recipient, context, and facilitation. With our innovation, which is e-tracker, we compared the evidence or consistency recommendation of electronic immunization record practice with the status of the immunization practice during our study period, and the change happened after the implementation strategy. So with the innovation, the recommendation said that a child who receives a vaccination has to be electronically recorded at the health facility during immunization session. So the state of the practice in Rwanda, the immunization data were recorded on paper first during the immunization session and then transferred into the e-tracker some days after immunization session by a data manager or available trained nurse. But after the facilitation strategies within the intervention group, all immunization data were recorded in the e-tracker during vaccination session, means that the point of care with the patient or within 24 hours of immunization session by immunization nurse. So the recipient users need to have knowledge and supportive resources to adopt and use the innovation, or example, computer equipped with internet connection. The status that was there during our study period, the health facilities were equipped with desktop computers and the tablet PC for outreach immunization. However, user received limited training on e-tracker, and health facility often experienced turnover of trained staff, mainly the data managers and immunization nurse. So with the change after practice, 1 more nurse in addition to the responsible immunization nurse were trained by data manager in championship through running collaborative WhatsApp group of nurses. The context, the recommendations say that support is needed to help people change their attitude, habit, skills, and way of thinking. So with the state of the immunization practice, top leader initiative to support e-tracker were initiated through external organizations such as Gavi and UNICEF. Paper was still in use due to insufficient training of the users and the turnover of trained staff. With the change after practice, the change after facilitation strategy, health facility leaders and hospital were involved to support the data manager championship in training the local nurses. For facilitation, there were limited facilitation in terms of technical support and user training. And here, the external facilitators, which are researchers, together with the expert facilitators from the top level, RBC and the Ministry of Health, supported the internal facilitators around the innovation content e-tracker to develop the appropriate skills for internal facilitator to serve as the local expert on the e-tracker intervention. So here are the results from the evaluation questionnaire. We had on total 46 participants, with the big number of female, 63%, and 37% of male, and the predominant age group was the group from 41 to 46. And the more nurses, the more participants were general nursing background, others were midwifery. With the experience less than 1 year were 17.4, and those with greater than 10 years of experience were 8.7. So on 12 received the intervention, and 34 did not receive, serves as control group. So from the result of independent t-test, with our free measure of intervention, we saw that the acceptability and feasibility showed significant difference compared to the control group, because it has the higher number, the higher level of mean compared to the control group. So, but with the appropriateness of the intervention measure, it seems there is no significant difference. All groups consider the e-tracker intervention to be appropriate in the immunization at the same level. With the training satisfaction, it seems the group that received our additional intervention and the group that received the general training from RBC, from Ministry of Health, they just received training at the same way. There is no difference between the level of the satisfaction among the two groups. However, the training was appreciated at 91%, 91.3%, and they provided the participant with sufficient skills to use the e-tracker. So while 60.9% of participants affirmed that the training covered all questions they have and challenge they had about e-tracker, 71%, 71.7% also said that they still need additional training to successfully use the e-tracker. So with the conclusion and the recommendation, facilitation strategy co-designed with user can overcome resistance to change among the immunization nurses and improve acceptance of digital tools such as e-tracker. The result also showed the same level of satisfaction of training received in both intervention and control group. And the e-tracker was perceived to be appropriate in both groups at the same level, meaning there is no significant difference. That means that e-tracker has been improved over time and works well within the context. So the high acceptability and feasibility in the intervention against control group means the facilitation strategy received have enhanced the user skills and satisfaction with the e-tracker. The user felt confidence adopting and using the e-tracker. So this study addresses the World Health Organization's call for implementation research to identify crucial factors affecting scalable and sustainable implementation of digital health intervention for health system strengthening for resource-limited setting. We recommend that future efforts should focus on incorporating local champions to motivate and enable sustained e-tracker use among immunization health workers countrywide. Future electronic immunization registry implementation stand to benefit from continuous monitoring of electronic immunization registry adoption and acceptability during implementation. Here are the references. Thank you. If you have a question, you are welcome. Thank you so much.